Yes, sir.
Can you please check the sound?
Yes, sir. It's fine, sir. Fine, sir.
And video as is visible?
Yes, sir.
Clearly?
Fine, sir. Yes.
Very well. Thank you so much for confirming, Shiva. Really appreciate your support.
Thank you, sir.
And very good evening to everyone. I hope I'm quite audible and visible too. Yes, as Shivang has confirmed. Proceeding with our with the agenda of the evening. I'm Dr. Pawan K. Gupta, Member Executive Committee, Association of Environmental and Occupational Health, Delhi, Delhi branch of Indian Association of Occupational Health, and Secretary AEOH, Haryana branch. On behalf of AOSD, extending a very warm welcome to esteemed speakers, panelists, and attendees. Gratitude and thanks to all of you for joining us this evening. It's a matter of great pleasure and privilege, as before, to get an opportunity to host 56th webinar of AUSD under AUSD's ENOCH, Environmental and Occupational Health DigiConnect initiative. Sincere gratitude and thanks to the executive body for extending the opportunity. And I really extend thanks to the Secretariat for their continued engagement and support, which has enabled us achieving this milestone of 56th webinar on the platform. As always, we have great lineup of speakers who would deliberate and share their informative thoughts on most pertinent and apt topics, as we will see. And before proceeding further, just to quickly touch upon the timelines of today's webinar, we have allocated a slot of 20 minutes each for our esteemed three speakers. And I can see that Dr. R.K. Chaudhary, Dr. Colonel Jasjit Singh, and Dr. Rajiv Kumar Jain, who are our esteemed speakers who have already joined in. Most welcome and very good evening once again to our esteemed speakers. Each session would be followed by Q&A, round of 5 to 7 minutes. So thus we are looking at approximately an hour and a half knowledge feast, and which we are expecting to be wrapped up by close to 8 p.m. Kindly requesting support of our esteemed speakers on the scene so that we are on time. And before I hand over this e-flow to our esteemed speaker, I would request esteemed panelists and attendees to please keep posting your questions and queries in Q&A box. You can use the chat box as well, and keep sharing your thoughts through chat box as well, or as you please, you can directly mail me or text me as well. If you have the number, you can send the queries to Secretariat as well. We would try to take all of them in order of their appearance on the screen with due consideration to the available time. Now, without any further delay, kindly requesting our very own Dr. Gajendra Kumar, President, AUSD, to please give inaugural address and declare the webinar open. Over to you, sir.
Thank you, Dr. Pawan.
Thank you, sir.
Good evening, friends. I welcome you all to this webinar, our 56th series in a row. For last more than 1.5 years, we are continuously on every Saturday meeting through this webinar and discussing all the technical issues, not only regarding COVID, but other medical emergencies and medical conditions as well. Today, we have got our three esteemed speakers with us. Dr. R.K. Chaudhary, he is a oncohematologist. Dr. Colonel Jasjit Singh, he is a hematologist, and our own speaker, Dr. Rajiv Kumar Jain, who is our Vice President. And the topics are very important because in this COVID wave, most of the other conditions, especially the cancer patients, they have suffered a lot because of the delay in getting the treatments and other reasons. So these all the topics are very important. So I welcome you, welcome all the three speakers as well as all the other participants. With these few words, I hand over to Dr. Pawan for further proceeding. Thank you.
Thank you. Thank you so much, sir, for your kind gesture and with your permission, taking the agenda ahead. And we have among us, as I mentioned, Dr. R.K. Chaudhary, our first speaker who would be deliberating on diagnostic approach to CML. And very good evening, Dr. Chaudhary.
Thanks, sir. Good evening.
Yeah, you can please. That's such a pleasure to see you.
That same here, sir.
Thank you so much. I will take the opportunity to give a brief introduction of about you to the esteemed audience here and everyone. So before I hand over this e-dais to Dr. Chaudhary, Dr. Chaudhary is head and senior consultant medical oncology and hemato-oncology Metro Hospital and Cancer Institute, New Delhi. Dr. Chaudhary is a renowned medical oncologist and hemato-oncologist of Delhi NCR region. He's an alumnus of one of the India's most premier institution, medical institution, Maulana Azad Medical College, New Delhi. And after completing his MD, medicine from Lady Hardinge Medical College, Delhi, Dr. Chaudhary went to pursue his postdoctorate degree in oncology from yet another Apex Institute of India, Army Hospital Research and Referral, New Delhi. Dr. Chaudhary has a special interest in academics and regularly attends both national and international oncology conferences as faculty. And he started his oncology practice from Apollo Hospital, New Delhi, and presently he's working with Metro Hospital, Preet Vihar and Noida as head and senior consultant medical oncology and hemato-oncology. Besides being a member of various national and international oncology forums like National Academy of Medicine, Medical Sciences, European Society of Medical Oncology, American Society of Clinical Oncology, Dr. Chaudhary is founding member and vice president of Young Oncologists Group of India. That's really good to learn. And he has expertise in treating all kinds of cancers like lung cancer, breast cancer, ovarian cancer, stomach cancer, colon cancer, lymphoma, leukemia, and multiple myeloma. That's such a wonderful profile, Dr. Chaudhary, and we are privileged to have you with us this fine evening. We look forward to your thoughts. E-dais is all yours. Over to you, Dr. Chaudhary. Thank you.
I said at the outset, I would like to thank you, Dr. Pawan, sir.
Thank you so much.
For such a beautiful and elaborate introduction. Thank you so much. Also, I would like to thank Dr. Gajendra Kumar, sir, and all the esteemed audiences. I would like to thank you, this Novartis and the team, for giving this opportunity. So, am I supposed to share the screen or somebody else share the screen?
So as convenient to you, sir. If you would like to share your screen and
let me try if I can share the things.
Yes, please.
So, start broadcasting.
No problem.
So please confirm
Yeah,
it is available.
Yeah, it's appearing. Let us see if it is in order that we can see the slides. Or if secretary has your slides, then maybe.
Yes, sir. Can I share, sir? Can I share from here?
Yes,
yeah, please.
Yeah,
okay,
so,
okay.
So
Dr. Chaudhary, you can
talking.
take. Yes, please. You can take help of secretariat, and they will switch on the slides whenever you suggest.
Please.
Yeah, please. Very well. Can you see the screen, Dr. Chaudhary?
Right. Thank you so much.
Most welcome.
So why we chose today's topic of CML is because CML being one of the most common hematological malignancy, and this is one of the most common malignancy which is being regularly ignored just because of lack of some insight about this thing. And CML is the thing, if we treat it properly, it gives very, very good quality of life. In fact, we don't consider CML as the malignancy. In fact, it is a chronic disease, just like another chronic disease like diabetes or hypertension, where the treatment is only one pill has to be taken. So it is basically chronic disease rather than a cancer. Once the patient hear the name of blood cancer, they are very scared. But CML, after the discovery of this TKIs, has now it is a chronic disease. So we chose this CML. Most of us know or are aware about the things, so we'll revise the things, right? So I'll start from the another point about the CML is if it is left untreated, then it can create the havocs. It can transfer into the accelerated phase and blast phase, and which can be life-threatening. So it is very, very important to diagnose the CML at as early as possible and treat as per the international guidelines. So treating on the right line can give the very good results, and ignoring it can lead to very, very dangerous situations. So starting from the, we'll start from the basic hematopoiesis, which we have all read in our physiology days. Then we'll come to the case scenario. So this is basically hematopoiesis, where we all know these are the multipotent hematopoietic stem cells. They have the tendency to go into any directions. They are broadly classified as the lymphoid progenitor and the myeloid progenitor. Lymphoid are ones which further divide into the natural kill cells, or either B cell lymphocytes or the T cell lymphocytes. Myeloid progenitors further divide into the mast cells, which are play very important role in the hypersensitivity reactions, then erythrocyte, thrombocytes, and WBC, white blood cells, which are again divided into basophils, eosinophil, and neutrophil and monocytes. The next slide, please. So depending on the at which level of cell maturation this dysregulation occurs, various type of leukemias arise, or various kind of blood disorder arises, whether they are the progenitor cell level or they are at a mature level. So we know these all four leukemias, like all AML cell, which we used to read in the pathology books. So ALL, AML, CML, and CLL. And as per the age advances, these leukemias develop. So ALL, most cases, they are the disease of the younger population. Then AML, which is around 15 to 39 year of age. Then CML around 40 to 60 year of age, and CLL, which is beyond 60. This is common, but it is not necessary that this is a very strict age group for the ALL can present in 50s, and AML can present in 70s, and CLL can present in 20s also. Next slide, please. So why there is a delay in providing the timely treatment? This can be because of three reasons. One is ignorance by the patient. Patient might not able to notice his or her symptoms, because in the CML, which is the topic of today's discussion, in the initial part, there are no as such symptoms, and most of the CML, if they are diagnosed in the early stages, they are purely because of incidental diagnosis. So most of the patient doesn't have symptom at the early stage. So even if there are symptoms which start from the fatigue and the pain, early satiety and pain in the abdomen because of massive splenomegaly, and the Indian population tend to ignore these symptoms. So if the patient goes to a primary physician and they by chance they get the blood reports or the ultrasound, they'll come to know there are marked leukocytosis and the spleen is enlarged. So because one is patient is unable to notice the symptom. Second is by the physician, the primary contact person, he might ignore the things. If there are TLC raised around 20,000 or 25,000, sometimes physicians consider or relate it with the infections. And since the patient doesn't have symptom, so you don't tend to refer a patient to a specialist. You would like to treat the patient with the antibiotic. And sometimes this initial phase of CML, the TLC vary. The patient presents with the 22,000, and after course of antibiotic, the TLC might come down to 15 or 17,000. And the patient and the primary physician might take it as a response to the treatment. And that will be another reason to ignore the patient. Thirdly, delay in the prompt administration of the treatment can lead to the delayed treatment. So these are the 3 points where these can lead to delay in the diagnosis. Next slide, please. So now coming to a real life case scenario. So we have the patient who is 53-year-old. He has reported history of fatigue, general malaise, and a weight loss of 16 kg in last 6 months, and now comes to us. So next slide, please. So of course, we'll advise, we'll do the clinical examination, and which led to mild tachycardia, and there is a palpable spleen extending around 10 centimeter below the costal margin, and we have done the complete hemogram test. So this is the complete hemogram. We can see hemoglobin is 10, slightly lesser than the normal range. Hematocrit is 30, which is again lesser, and there is a marked leukocytosis around 3 lakh TLCs. Platelet are within normal limits, 4,29,000. MCV, MCH, and MCHC are within a normal range. So looking at this picture, what are the differential diagnoses that comes to our mind? So of course, TLC of 3 lakh, we won't consider as a leukocyte reaction or the infection as the differential diagnosis. Definitely, we'll consider about the some blood disorder, blood malignancy. What are the possibilities? The patient has symptom of malaise and the fatigue and doesn't have the fever, then and platelets and hemoglobin are normal, then definitely this is a case of chronic leukemia, not the acute leukemias. So 2 possibilities are there. It can be myeloid leukemia, which is a CML, or it can be CLL. So what we would like to order at this CBC is, we would like to order a peripheral blood smear to see whether there are mature sites, mature leukocytes, or they are the immature or the blast cells are there. Apart from this, we would like to order the further investigation that might include the bone marrow and Philadelphia chromosome analysis, BCR ABL. Next slide, please. So what is your differential or provisional diagnosis, and what we need additional diagnosis that we discussed just. Next slide, please. So this is the differential leukocyte where it says the blast is 5%, basophils 5%, band neutrophils 32%, segmented. So we can see there are the various range of leukocyte are all the mature and immature cells are increased, but most commonly the mature leukocytes are increased. So it is a myeloid thing and it is a chronic thing. So based on this, we can diagnose this is a chronic myeloproliferative disorder. So what are the differential diagnoses in chronic myeloid difference? CMPD. So one is the CML and others are polycythemia vera, essential thrombocytosis, and myelofibrosis. But in the polycythemia vera, there is a marked rise in hematocrit and HB, and might be leukocytosis and thrombocytosis there. Similarly, in the essential thrombocytosis, there should be thrombocytosis beyond the 7-8 lakhs. So these differences are lesser in the order. So CML is the in the upper order. Next slide, please. So they straight away bone marrow aspiration done, and we can see that the increased basophils in the red arrow and the eosinophils. So basophilia is one of the diagnostic marker on the CML. What is the confirmatory marker? For confirmatory diagnostic test in the CML is the Philadelphia chromosome, which we can diagnose or detect in the either karyotype or by RT-PCR or FISH. Next slide, please. So Philadelphia chromosome is it is a balanced translocation, reciprocal translocation between the chromosome 9 and chromosome 22, where BCR and the ABL fusion is there, which is the hallmark of the CML diagnosis. And it can be diagnosed or detected by either karyotyping, which is the study of whole this is chromosome, or it can be detected by the FISH, or for the quantitative BCR, the RT-PCR is the gold standard. Next slide, please. So these are the various reports like flow cytometric analysis, which we normally doesn't order for the diagnosis of the CML, but here the flow cytometric shows the CD33 and CD117 positive myeloblast population, and the fish has detected BCR-ABL, which is a confirmatory of the CML. Next slide, please. So we discussed what are the differential diagnosis. When the TLC is marked, then the leukomet reaction is one of the differential diagnosis, but we know that in the leukomet reactions, their TLC almost never goes beyond. Sorry for the interruption. So in the leukomet reaction, TLC almost never goes beyond the 50,000. There are on the peripheral smear, we'll see toxic granulocyte vacuolations, the whole body, and absence of basophilia. That's what we were discussing, that the basophilia will be seen in the CML, not in the leukomet reaction. And lab score, which is either normal or it is increased. The other differential we have already discussed, essential thrombocytosis, polycythemia, and the AML. It's not necessary that absence of Philadelphia chromosome will be there. There are pH positive AML also, but in the AML, we will see the frank blast. More than 30% blast should be there in the periphery. Next slide, please. So patient was diagnosed as a case of myeloid leukemia, and in the CML, we know there are three phases or three stages. One is the chronic phase, where the 80 to 85% of patients are diagnosed. Then around 10% of patients are diagnosed in the accelerated phase. In the accelerated phase, there is marked leukocytosis. Apart from leukocytosis, the other cell lines like hemoglobin and thrombocytes, platelet lines are also affected. So there may be anemia and thrombocytopenia. Then there will be increased blast more than 5%. So 5 to 15% blast will be there in the, like 15 to 30% blast will be there in the accelerated phase. 5% of the patient present with the blast phase, which is as bad as the acute myeloid leukemia, which is considered as the AML only, where the blast counts are more than 30%. Next slide, please. So these are the stages with the chronic phase, accelerated phase, and blast crisis. In the chronic phase, if the patient is diagnosed, it may last up to 4 to 6 years, or sometimes with the development of this new second generation TKI, we are seeing the patient beyond 10, 15 years in the chronic phase only. So 85% of the patient present in this phase, then where the in the marrow or the peripheral blasts are less than 15%. In our case, it was 5%. In the accelerated phase, patient can live up to 1 year or more than 1 year, and then the patient will progress to a blast crisis. Once the patient is diagnosed or gone into the blast crisis, most of the patient will die within 6 months. This is a very, very poor prognostic, and this is rapidly fatal, and it has to be treated like acute leukemias. It is pertinent to mention here in the blast crisis, though it is a myeloid malignancy, CML is a myeloid malignancy, but when this CML converts into the blast crisis, 2/3 of the patient will convert into the myeloid leukemia, and 1/3 of the patient or 1/4 of the patient will be lymphoid leukemias. So it can be either ALL or it can be AML. So most commonly it is AML, but sometimes 1/4 to 1/3 of the patient will be converted into the ALL. Next slide, please. So this is the typical CBC of a CML patient where the WBC are raised in the chronic phase or accelerated phase or blast crisis. In every phase, the WBC will be raised. Blast, there is a definition if they are less than 15% or 15 to 30% in the accelerated phase, and if they are gone beyond the 30%, it will be called as the blast crisis. Basophil are increased in all the phases. In the platelet, in the chronic phase, it are normal, but once they transform into the accelerated phase or the blast phase, there will be thrombocytopenia. Next, please. So what are the goal of the CML therapy? First is to diagnosis as early as possible, diagnosis in the chronic phase, because most of the patient, if we diagnose in the chronic phase, as we discussed in the previous slide, they'll run in the chronic phase for 10 to more than 10 years, like diabetes or hypertension. So the second goal is to give a deeper response, and by getting the deeper response, we'll be able to prevent disease progression to the either accelerated phase or the blast crisis, ensure the best possible duration and the quality of life, offer a treatment discontinuation of patient achieving a deep molecular response. This is the nowadays this is the goal. The patient doing well with the 0 pH, like a Philadelphia chromosome, can we discontinue the treatment? So there are no current guidelines whether we can discontinue the treatment, but there are few papers which recommend if the patient is doing very well for a couple of years, then we can slowly taper down the therapy and we can almost stop the therapy. Then the aim is potential achieve a cure, whether there is a treatment option which can cure the CML. Next, please. Can we, okay, sorry. So what are the first line treatment? What are the second line treatment? What are the options beyond second line? So this is a very simplified chart. So there are oral therapies, oral chemotherapy, which we call magic bullets, is the treatment of choice for CML. There are 3 tablets which are available to start with. We can start either of them, either first generation TKI, which is imatinib, with the name of VNET in the original, but now many Indian players has come with the generic medicine, and they are very less cost. We can provide cheaper cost pay. So either imatinib, which is 400 milligram OD, or nilotinib, which is 300 milligram BID, or dasatinib. Nilotinib and dasatinib are the second generation TKI. So these all 3 TKIs are recommended as the first line therapy, depending on patient's profile. If the because there is a difference the rate. So if the patient is poor, imatinib is good enough choice. But if you want a quicker and a deeper response, then nilotinib and dasatinib are the drug of choice. But let me clarify here: if the patient presents with a very high leukocytes, we need to give the hydroxyurea to decrease the TLC to around 20,000, then start these TKIs. In the second line chronic phase treatment, the another TKI, the first, if we have started imatinib, then we can shift to nilotinib or dasatinib. If we have started on the nilotinib, we can shift to dasatinib, and if we have started with the dasatinib, we can shift to nilotinib. So depending on the drugs. Then there is a test. Once the imatinib failure is there, then we can do the imatinib mutation resistant analysis, IRMA test, and based on that test, there is a drug sensitivity report also, and depending on the drug sensitivity report, we can either switch to the nilotinib or the dasatinib, or there are new TK also, ponatinib and bosutinib, we can shift to them also. Now, once the patient is gone to the accelerated phase and the blast phase, they need to be treated with the higher dose of the same drugs, either imatinib in the dose of 400 milligram BID, or dasatinib 70 milligram BID, or 140 milligram OD. And apart from this TKIs, patient, most of the time patient needs the chemotherapy also, and chemotherapy regime here used is the same regime which is used for the acute myeloid leukemia. So apart from the AML regime, we need to treat them with the higher dose of TKI. And once the patient is stable or get into control, the allogenic stem cell transplantation is recommended for better outcomes. Next slide, please. Okay, so we are done with the presentation. Happy to answer the questions if anybody has.
Thank you so much, Dr. Chaudhary, for having up within the time frame. I really appreciate, and thank you so much for sharing your thoughts on CML. Quite in an easy manner and comfortable manner. Before I open this to the floor for questions, just a quick one from I said, I mean, you mentioned that the count of the patient WBC count was around 3 lakhs. So, and the symptoms were not that significantly visible. So is it like quite normal going to 3 lakhs and then also patient is not having any significant symptoms, noticeable symptoms rather?
Right. Thank you, sir, so much for asking us this question. This is a very important question because when we see the count of 3 lakh, everybody expects equal symptoms, at least of leukocytosis or leukostasis. But since the CML, the most of the cells are very mature and they are very small, so they don't cause the leukostasis also.
Okay. We have some issue with the screen. Your screen is frozen. Dr. Chaudhary.
So is it okay right now?
Yeah, good. Yeah.
Okay.
Good.
So thank you, sir, for asking this question. Because most of the patient, even at the count of 3 lakh or 4 lakh of CML, they doesn't show any symptom of the leukostasis. Because the cells are very mature and very small in size, and they don't clog or block the small vessels. And contrast to acute myeloid leukemia, where if the counts are very much high of 3 lakh or 4 lakh, they might present with the headache, dizziness, kind of symptoms because of leukostasis, and where we need to decrease the counts very immediately, sometimes by pheresis also. But in the CML, this patient might present with absolutely malaise and the heaviness in the left hypochondria because of massive splenomegaly and early satiety.
Okay. Thank you so much for answering that. I think that helps a little bit. We will definitely have to dive deeper and not taking any more time, holding any more time. I'll straight away go to a question which appeared first on the screen by Dr. Damodar Lele. Dr. Lele, you can actually unmute and ask. Otherwise, I'm going to ask on your behalf, and then definitely you can also join in the discussion. He has asked, is peripheral smear not a part of CBC as preliminary investigation? Why do we have to ask for it separately? That's a question from Dr. Lele.
Sir, can you repeat, please?
Is peripheral smear not a part of CBC? Initially, you mentioned that if CBC, the picture is not clear, then we have to go for peripheral smear. So he is asking, is it not part of preliminary investigation itself? Why separately it has to be asked and taken?
No, if the patient comes with the malaise and happiness in the body, or it's not necessarily that we'll ask for a peripheral smear at the beginning only. We'll ask for the CBC, LFT, KFT, ultrasound, and it's in the most of the labs, CBC doesn't include the peripheral smear. So there are different terminology like complete hemogram. So in some lab, complete hemogram includes the peripheral smear also. But the CBC, which name itself says the complete, but sometimes it doesn't include the peripheral smear. But depending on the pathologists, some pathologists, when see this leukocytosis, they make the slide and do the peripheral smear at the same time.
Okay. Yes. Probably that's the reason. So I think that answers Dr. Lele's question. The other question is from Dr. Muralidharan. Benzene exposure is known to CML. How can we diagnose it early if we are doing 6 monthly examination for those working with benzene?
So leukocytosis should be the first sign where we should pick up the things. And if we are seeing a sequential rise in the TLC, then we should be more concerned about the things. We should be suspicious about the things.
Okay. Thank you so much. Now I open it to our esteemed panelists. If anyone has any question for Dr. Chaudhary, please.
I got one small question.
Sure, sir.
Yes,
sure.
sir.
See, the symptoms are so common and vague, and especially in the rural and semi-urban areas, it is very difficult even for the physician to think about the disease. So how many cases you directly see which are coming to the hospital in the blast stage?
So less than 5%.
It is less than 5%. So that means most of the cases are being diagnosed well in time and put to the treatment.
No, not necessarily. The CML is a very chronic disease. Even if you don't treat patient for the 2 years, it won't convert into the blast crisis as such without treatment also.
Okay.
Great.
Right.
So
there are patients which we see in the clinic and we diagnose them with CML. We advise them the treatment. They don't take the treatment, and they come after the 2 years and they are very asymptomatic.
Okay. Thank you.
Thank you so much, sir, for asking this question. Thank you, Chaudhary, for taking that question. I do not see any more hands here or any more questions. So would like to thank you once again, Dr. Chaudhary, for taking out time and joining us and sharing your thoughts. We really appreciate that. And with that, probably we'll be moving to the next session, to our next esteemed speaker. And we thank you once again, Dr. Chaudhary.
Thank you, sir.
Thank you very much. Well, we can very well see Dr. Colonel Singh all very much on the screen. Such a pleasure. Thank you so much, sir, for joining us. Can you hear us clearly, sir? Just wanted to check quickly. We can definitely see you, but we are not able to hear you if you're saying anything. Dr. Singh? Dr. Colonel Jajit Singh.
Still not audible, sir.
Yes. Maybe unmuting is required, but we can see that your mic is unmute, sir. Can you hear us, Dr. Singh? Okay.
Sir, unmute, please. You have to unmute.
Sir, still we cannot hear you. Okay. So while maybe Dr. Singh is probably looking into the issue of the mic.
Please, Dr. Bhavan, ask the secretary to please check what is wrong, because
Yeah.
mic is on.
Yes, sir. I am checking, sir. I am checking it.
Please check.
In the meantime, I think since Dr. Singh is very much on the screen, I would
You can give the introduction.
Yes, I would like to proceed with the introduction, and I hope he can hear us. Sir, can you give a nod that you can hear us? Oh,
Okay.
perfect, sir. Thank you so much. So we will run through the introduction as you can hear us. In
Thank
the
you.
meantime, secretary will coordinate with you and fix the mic issue. Okay, sir? So thank you to Dr. Singh for sparing time, and it's my pleasure to introduce him to this platform. Dr. Colonel Jajit Singh is HOD and Senior Consultant, Clinical Hematology Department, Sir Gangaram Hospital, New Delhi. Dr. Singh is going to deliberate on pancytopenia. Is it a case of anemia? And Dr. Singh is currently working as Senior HOD and Senior Consultant, as I mentioned, and he commissioned in Armed Forces Medical Services of the Indian Army in June 1988, same month in which we are right now, but the year was 1988. Yes, and did internship in the busiest hospital of the Armed Forces, that is Base Hospital, Delhi, Kant. We very well know that. I think we can hear you, Dr. Singh, now.
Oh, that's great. That's great.
Absolutely wonderful, sir. Good to hear. So I'm continuing with the introduction, please. He worked as a primary care medical officer, serving as a doctor to Indian Army troops in the in operational and difficult terrain of J&K, and later as medical officer at Military Hospital, Kirki, Pune, from 1989 to 1995. He did his advanced course, MD in Internal Medicine, from Army Hospital, RNR, as we know, New Delhi, from Delhi University from 1995 to 1998. After completing post-graduation in internal medicine, he worked as a physician, medical specialist from 1998 to 2004 at a military hospital in Gangtok, Sikkim, followed by a military hospital, Amritsar, Punjab. He worked as a part of a very active hematology and BMT team in the premier Armed Forces Hospital, Army Hospital, RNR, and then even functioned as the HOD of the department, participated in a very active stem cell transplant program. He established and pioneered the Department of Clinical Hematology at Chandigarh, Chandi Mandir, first clinical hematologist to be posted to this large tertiary care center, and made a functional department which catered to all hematological diseases, benign as well as malignant. Patients were managed as inpatients as well as OPD. Great to learn about all the achievement that you have, sir. And I once again thank you for sparing your time. The e-platform is all yours, sir.
Thank you. Thank you so much. Dr. Pavan, for the kind words you've used. I really don't know whether I deserve those kind words, but thank you so much for firstly having me on this platform. And I take this opportunity to thank Indian Oil Environmental and Occupational Association. And I thank the sponsors, Novartis. Can you hear me? Am I
Yeah,
audible?
very well. We can hear you. Thanks to you
Okay.
for all the
Thank
for your kind gesture. Yeah.
And I even thank Usha here, who's from Novartis, to help me set this up. Otherwise, we were in a little bit of a technical glitch. So
Okay.
I've been told to share my views, share my thoughts on an important hematological disorder. And why it's important for this forum is that it's something which will come primarily to a primary care physician, followed by maybe a physician. And it's very important. It's very important in the outcome that this be recognized at the outset. The earlier is the diagnosis of this condition, which we call as aplastic anemia, the better will be the outcome. So the topic is pancytopenia. Is it really a case of aplastic anemia? So, ladies and gentlemen, pancytopenia means we are all aware that basically there is a reduction in all the 3 cell counts of the blood, which is the red blood cells, the white blood cells, as well as the platelets. Now, pancytopenia could have various causes, but one of the most significant and, if I may use the word, dreaded causes would be an aplastic anemia. It is sometimes even worse than having a frank malignancy because it poses a lot of challenges. But the diagnosis as well as the therapy has evolved over time. And in the next few minutes, I will attempt to share with my colleagues how has the journey been. So can we have the next slide? I would be happy to entertain any queries at any time. If you want to save it for the end, I would be happy to answer it at the end. Okay.
No, sir, sure. I'll moderate that, sir. I'll moderate.
Yeah,
Sure.
that's it. So yeah, so we have a middle-aged man who reported to the department of in a dentistry department with bleeding of gums of a month's duration, and he did not give any history of basically any other significant bleeding history, maybe a rectal bleed, hemoptysis or hematomesis. And he had visited a local physician 20 days back and had been prescribed antibiotics, metronidazole and an anti-parasite drug albendazole, some vitamin supplements. After that, he reported easy bruisability and cutaneous hemorrhages in the form of ecchymosis and petechia on the arm, legs, and buttocks, gluteal region. He had extreme pallor when his lower palpebral conjunctiva was examined, as well as the nail beds. And there were wet purpura. By wet purpura, I mean that there were evidence of oral mucosal bleeds. So we carry on the evaluation of this patient in the next slide, please. So we see that a complete blood count revealed he had a significantly low RBC count, which should have been anything from 4.5 million to 6 million. In his case, it was just 1.92 million. He had severe anemia and his platelet count was an abysmal less than 20,000. His total leukocyte count, which should have been normal between 4,000 to 10,000, was just 1,100. He had a significantly elevated erythrocyte sedimentation rate, and his bleeding time was dangerously high at 15 minutes. A peripheral smear revealed anisopoikilocytosis, by which I mean there was variation in the size as well as the shape of the red blood cells. There was a reduction in the WBCs and also a very significant reduction in the platelets. A bone marrow aspiration was advised, and it revealed bone marrow aplasia. When we mention the word aplasia, I would like to emphasize aplasia means that there was no cellularity, that the bone marrow was bereft of hematopoietic element, basically replaced by fatty tissue. So bone marrow aplasia is something which is a very, very unpleasant finding for any hematologist or hematopathologist, and it signifies that the bone marrow is basically nearing emptiness. There is no potent hematopoietic tissue inside. The diagnosis of aplastic anemia was suggested, and the patient was referred to the Department of Hematology. Now, what is aplastic anemia? What is aplastic anemia means? The plasticity of the marrow is gone. The plasticity of the marrow is no more there. And why does this occur? That there is the hematopoietic, the potent hematopoietic element of the marrow has been replaced by nothingness. There is the cellularity of the marrow is less. As a rule of thumb, if you subtract the age of a patient from 100, is the cellularity you should expect in a normal marrow. For example, there's a person whose age is 30 years and you do a bone marrow, his cellularity should roughly be 100 minus 30, anything from 60 to 65%. And if the cellularity as a general rule is less than 25 to 30%, we consider it a hypocellular marrow. And the most important cause of a hypocellular marrow, which we must keep in mind predominantly, is an aplastic anemia. So in aplastic anemia, the marrow, the hematopoietic cell loses the plasticity of manufacturing all the three hematological lineages. Those are the red blood cells, the white blood cells, as well as the platelets. Next slide. So what is aplastic anemia? It's predominantly an autoimmune disorder. It's an autoimmune disorder in the bone marrow associated with not only a platelet depletion as this slide shows, but even a depletion of the white blood cells and a depletion of the red blood cells. So a characteristics of an aplastic anemia would be a decrease in the bone marrow hematopoietic precursors, which I've already mentioned. On the peripheral blood, you will find all the cell lines decreased, and that would mean there's a pancytopenia, decreased RBCs, WBCs, as well as platelet counts. And there would be no underlying identifiable secondary cause to it. You wouldn't be able to say that this person has a carcinoma breast, which has infiltrated the marrow. It's not like that. It is an absence of any other disease. You have a hypocellular marrow reflected in the peripheral blood by a pancytopenia, which promotes you to think of the diagnosis of aplastic anemia. So generally the hemoglobin will be less than 10 grams per deciliter. The platelets would be much lesser than 50,000 per microliter, and the neutrophils would be less than 1,500 per microliter. And as has been written rightly, it has a very serious impact on the patient's lifestyle and quality of life, but unfortunately also on the quantity of life. It is fatal if left untreated, or may lead to other significant malignant conditions. It may evolve to a myelodysplastic syndrome or even an acute myeloid leukemia. Having said this, I come back to the first slide, that it is extremely important for my colleagues who are first going to see this patient as a general physician or as a medical specialist to be able to suspect the presence of an aplastic anemia by being informed of his presentation, and then probably take the next step to evaluate him. May I have the next slide? So what is the epidemiology of aplastic anemia? Generally, in about, I would say, in about 85 to 90% epidemiology, basically there are two age groups. One is in the younger, between 10 to 25, and then in the older. It's predominantly, you'll find it occurs in the younger age group. And it is associated with premature mortality, is a no-brainer. And only in a very small minority, you'll be able to identify a cause, maybe an exposure to chemicals. I had a patient who was exposed to a fair number of chemicals in a factory he was working, and he came with very severe aplastic anemia. But these are exceptional. Mostly in more than 90% of cases, you generally would not have an identifiable cause. And what would those identifiable causes be? They would generally be exposure to some chemicals, benzene-based chemicals. There would be an exposure to radiation, or to an accidental exposure to radiotherapy, or accidental exposure to radiation in radionuclear plants. Then certain viruses are also known to, even hepatic viruses are known to cause an aplastic anemia. Then paroxysmal nocturnal hemoglobinuria can evolve to an aplastic anemia. And it's more common in our part of the world, that is the eastern part of the world, and the incidence is around 4 to 6 per million in the Indian population. Next slide. What would the clinical presentation be? It's a no-brainer to say that it would be a manifestation of the cytopenias. So somebody whose platelet counts are abysmally low would be predisposed to bleeding. And it could manifest generally, initially as a cutaneous bleed. A cutaneous bleed would be a petechial rash, as we're seeing in this photograph, or it may be wet purpura, which are generally the precursor of an intracranial hemorrhage. So you could see wet purpura. The differential of a wet purpura, we are all aware, is Koplik spots. They are small petechiae on the pharynx. A bleed could occur even in a more serious manner. There could be a hematemesis, there could be a rectal bleeding. But generally speaking, a cutaneous hemorrhage is the first initial manifestation, or a mucosal bleeding in the form of bleeding from gums, as happened with this gentleman, be the initial manifestation of a thrombocytopenia. Again, a low red blood cell count manifests as low hemoglobin, severe anemia. So you may have features of severe anemia in the form of easy fatigability, tiredness, and so forth. Low white blood cell count, low leukocyte count, less neutrophils, lymphocytes, compromises the patient's infection fighting capabilities and predisposes him to significant infections, which can be very difficult to overcome. Next slide, please. So it's important for us to know the severity of aplastic anemia, because the therapeutic algorithm depends upon the severity of aplastic anemia. So what is a severe aplastic anemia? As I told, a bone marrow cellularity of less than 25 to 30%, and an absolute neutrophil count of less than 500 with a platelet count of less than 20,000. What is very severe? Very severe would mean that the cellularity is it's the same, less than 25%. The platelets continue to be less than 20,000. The only difference is the absolute neutrophil count becomes less than 200 per microliter. And then what is non-severe aplastic anemia? Anything which does not fulfill the criteria of severe and very severe is a non-severe aplastic anemia. So why is this important? This is important in the therapeutic algorithm. A non-severe aplastic anemia we may take in a watch and wait policy, just keeping him under a monitoring. While for a severe and a very severe aplastic, we would have to be very proactive in our therapeutic algorithm. May I have the next slide? So, we've already mentioned the etiology, so we won't go over it again. Benzene, viral infections, pregnancy also. I mentioned inherited syndromes are important. So in the etiology of primary aplastic anemia, inherited causes 10 to 15%, and they are a distinct category by themselves. So there are various syndromes like Fanconi's anemia, dyskeratosis congenita, telomerase gene mutations. All of them I would want to specify have a chromosomal defect. There is a chromosomal fragility syndromes, Bloom syndrome, Fanconi's anemia, dyskeratosis congenita. All of them have a chromosomal instability, and that in fact has helped us diagnose inherited aplastic anemia. Why is it important? It is very important because the management of inherited aplastic anemia is very different from that. Out of 100 aplastic anemia, 85% will be acquired, 15% will be inherited. Suffice it to say that for an inherited aplastic anemia, you have no role of immunosuppressive therapy. You can only do a allogeneic hematopoietic stem cell transplantation. So that is where it's important for a clinician to understand that if somebody presents with an aplastic anemia in a very young age, we must exclude a congenital aplastic anemia. Next. Can I have the next slide?
So there is some disturbance. My apologies, Dr. Singh. There is some disturbance.
No, Dr. Pavan, please.
Yeah. I think there is some network challenge. There is a little bit of disturbance when you're speaking. The voice is getting slower. So maybe would you like to switch to another network?
I'll ask my technological brain here. That's Usha to help me out.
No problem, sir. No problem. While we fix that, I just wanted to quickly remind you also that we have 7 to 8 more minutes for the session. So would request your kind help on that.
Can you hear me, Doctor?
Yes, I can hear, but there was some lag in the voice. That is going to.
Is it okay now?
Yeah. So if you can switch off this video for a while, then I think the bandwidth will increase. Yes, maybe this for a while. Yes, sir. Yeah. Okay.
Now, can you hear me now?
Yeah, very well, and we can see your slides, sir.
Okay.
And I would request for your support on 7 to 8 minutes.
So this just shows the two age groups. One is the younger age group and the adult age group. Next slide, please. We've already mentioned about the inherited. So this is just showing us the Fanconi syndrome and the dyskeratosis congenita, in which you can see male changes. Next slide. We'll talk about the pathophysiology very briefly. That's more of interest to the etiology. Next slide. So suffice it to say that all of it is immune mediated. It is basically an autoimmune diseases which is being mediated by the T lymphocytes. We've been able to identify the T lymphocytes which are basically cytotoxic T lymphocytes. They are manufacturing a lot of chemokines like interleukin-2, tumor necrosis factor, and interferon gamma. And all of these contribute in the destruction of the hematopoietic pluripotent stem cell. Next slide. So this is basically an interplay of an increased number of activated T lymphocytes, which produce a number of lymphokines. We mentioned those lymphokines, and they upregulate the production of T lymphocytes, which causes apoptosis and destruction of the hematopoietic cell, resulting in the condition which we understand as aplastic anemia. Next slide. Dr. Pavan, am I audible?
Very well and very clearly. There is no lag. Thank you so much. Yeah.
So fine, we've just told destruction of the bone marrow may occur through two mechanisms, and the basic mechanism is the activation of the T lymphocytes, which causes an interplay and causes an increased production of cytokines, which causes the destruction of hematopoietic stem cells. Next slide. So what is telomeropathy? Telomerase length determines our life. So basically, telomere accretion has been recognized as a very important marker of the severity of aplastic anemia and reduced hematopoietic stem cell survival and proliferation, which results in marrow failure as well as dreaded chromosomal abnormalities like monosomy 7 and myeloid transformation to acute myeloid leukemia. Next slide. Mesenchymal stem cell defects from aplastic anemia are dysfunctional, and they do not inhibit T cell proliferation, which we are aware causes the destruction of hematopoietic stem cells. Next slide. How do we make a diagnosis? So the diagnosis is, next slide, the diagnosis is one of exclusion. And when I say exclusion, it is important for my colleagues to remember that the pancytopenia may not be a primarily a hematological disorder. A pancytopenia may be due to a salmonella infection. A pancytopenia may be due to an enlarged spleen, which is causing hypersplenism. But once we decide that a pancytopenia is due to a hematological problem, is not secondary to an infection, then the most important diagnostic tool you have is to see the machine which is making the hematopoietic cells, that is the bone marrow. So the most important investigation which we must do to evaluate and diagnose an aplastic anemia is that of a bone marrow aspiration and a biopsy. And this slide shows that aplastic anemia has an overlap with a lot of hematological problems. It may be an acute myeloid leukemia. You may have an acute myeloid leukemia in which all the cell lines are decreased. You may have a large granular lymphocytosis leukemia. You may have a paroxysmal nocturnal hemoglobin. You may have a Diamond-Schwartzman syndrome, and then you may have inherited aplastic anemia. So you must remember that a pure aplastic anemia may have an overlap with other hematological conditions which you need to actually differentiate. One of the most difficult problems that need to be differentiated is from a myelodysplastic syndrome. There is an entity known as the hypocellular myelodysplastic syndrome. This becomes extremely difficult to differentiate because even in an MDS, hypocellular MDS, the marrow is hypocellular. The point of differentiation will be that in a myelodysplastic syndrome, you probably will find a lot of cytogenetic abnormalities, which you may not find in an aplastic anemia. So severe aplastic anemia is a diagnosis of exclusion. A responsible hematopathologist will probably see to it that he's excluded other causes before he puts this diagnosis to you. But remember that the cellularity of the marrow is probably the strongest indicator of it being an aplastic anemia. Less than 25%, you must think that you're dealing with an aplastic anemia. Next slide. So what is the diagnostic algorithm? A good clinician will start with a history and a physical examination. History of, oral bleeds, mucosal bleeds. You must rule out any drug history which is causing a pancytopenia. You must rule out, has the patient been on a chloramphenicol, which has caused a pancytopenia? Has the patient received radiation? Has the patient received chemotherapy? And lastly, you must rule out rare inherited forms of aplastic anemia. Do a peripheral blood smear and document the patient having pancytopenia. As we've told earlier, a bone marrow examination is the pillar of our diagnosis, and followed by cytogenetics to see for any cytogenetic abnormalities. Next slide, please. So in a peripheral blood smear, we've already mentioned, will show a reduction in all the three cell lines. It may be the RBCs, it may be the hemoglobin, the white blood cells, the platelets, and the reticulocyte count. So you'll have a reduction in all these counts, resulting in a pancytopenia. So a pancytopenia with a reduced bone marrow cellularity translates to a diagnosis of an aplastic anemia, with one very important differential, that you're not dealing with a hypocellular myelodysplastic syndrome. Next slide. So a peripheral blood smear would probably give you a clue if you had a normochromic normocytic without any anisopoikilocytosis of an aplastic anemia. You had macrovenocytes. You would think of a megaloblastic anemia, teardrop cells, basophilic stippling, MDS, sickle cells. And, so basically a peripheral blood smear remains a very important diagnostic in our diagnostic algorithm. So generally in aplastic anemia, you will have nothing very dramatic in a peripheral smear except a pancytopenia. So if you have something abnormal, supposing you find blasts, then it points not towards an aplastic anemia, it points towards a pancytopenia in a hematological malignancy. So essentially, a peripheral smear, which is not showing any abnormal cells, but showing only reduction in the counts, would be suggestive of an aplastic anemia. Next slide. So in a bone marrow examination, we've already said it would be the bone marrow would be replaced by fat. The hematopoietic cells would be replaced by fat with a very decreased cellularity. Next slide. So morphological. So this is again the same repetition. Increased bone marrow fat caused by increased number of the fat cells and reduced hematopoietic element. Next slide. Bone marrow, we've mentioned this again, aspiration, empty particles. There would be hypocellularity. Supposing you found blasts, then it would be a leukemia. If you found dysplastic features, it would indicate a myelodysplastic syndrome. And these are the things that you need to keep in mind when a bone marrow is being evaluated. Next slide. I think we mentioned all this earlier, so we needn't go through this again. Next slide. So what would you see in peripheral blood cytogenetics? You have a peripheral blood, you see a pancytopenia, you do a bone marrow, and you find there are no abnormal cytogenetics. It points towards an aplastic. But you find there are abnormal cytogenetics. It points towards a myelodysplastic syndrome. You find blasts, it points towards an acute hematological malignancy, AML or ALL. And if you are suspecting an aplastic anemia with an inherited syndrome, then you must do chromosomal breakage studies, which is we can do a D-epoxybutane or a mitomycin sensitivity test, and they would show whether there's sensitivity to these would indicate an inherited aplastic anemia. Next slide. So I think we've gone through this, just a repetition. Next slide. Now, this is important. What would a clinician specifically keep in mind when you examine the eye in aplastic anemia? Does he have retinal hemorrhages? You do an oral examination. Does he have wet purpura? Does he have oral petechial hemorrhages? Does he have any evidence of a nutritional deficiency? In a cardiovascular examination, does he have cardiac failure secondary to severe anemia? In a respiratory examination, does he have any evidence of a respiratory infection secondary to a severe leukopenia? And in an abdominal examination, you must see for signs of any lymphadenopathy or any apparent liver or spleen being enlarged. Almost always in aplastic anemia, you would not get a liver or a spleen which is enlarged. So if you get a liver or a spleen which is enlarged, you must revise your diagnosis. You must think of another diagnosis. Generally in an aplastic anemia, you will not get lymph nodes which are palpable. You will not get a liver or a spleen which is palpable. Next slide. So I've already mentioned about splenomegaly, hepatomegaly. Whenever you're seeing for the skin, you're seeing for oral bleeds, musculoskeletal system, you're seeing for the phenotype of inherited aplastic anemia. A Fanconi's anemia has short stature, has no thumb or thumb abnormalities. Similarly, you would get abnormal nails in dyskeratosis congenita. And these are things which a good clinician should include in his initial clinical examination. Next slide. So I think this is a repetition of what we've just spoken. So we'll go to the next slide.
Yeah.
Because our presentation is more focused on aplastic anemia, we'll not go into NHL, CLL, or myelodysplastic, and we would proceed to the next slide. So these are various differentials which you would probably want to keep in mind. Cirrhosis, why? Because cirrhosis can give rise to a portal hypertension. Portal hypertension can give rise to a huge spleen, and a huge spleen can cause pancytopenia. But this is not really relevant so far as aplastic anemia is concerned. Hepatitis B and C rarely can be the causes of anaplasia by themselves. Next slide. So this is important. How do we treat? And the treatment is not the responsibility of only a hematologist. It's the responsibility of everybody, dear friends. And it may be the most important person who's treating is the primary doctor, the primary healthcare provider, because he must recognize that it's not a transplant which is going to save a human being in an aplastic anemia. It's a supportive care which is going to save him initially and get him clean to a place where he can be treated with curative intent. In the 60s, there's a good slide which shows that probably only anabolic steroids and supportive care in the form of transfusions and protection from infections was the only thing you offered, and survival was around 10%. In the 70s, there was a quantitative and a qualitative change in the therapy by immunosuppressive therapy having come. It made a quantum jump in survival, and it started touching 50% with immunosuppressive, that is anti-lymphocyte globulin of equine origin. So this was probably a very significant turning point in therapy. In the 80s, you had calcineurin inhibitors added on to the anti-lymphocyte globulin, which further improved survival. And 2010, immunosuppressive regimens have evolved even further. And now we have allogenic transplant as the mainstay of therapy in aplastic anemia. Next slide. So whom to treat? So if I have to summarize, when you have an aplastic anemia, there are two things you have to keep in mind. Is it a severe aplastic anemia or is it a non-severe? If it's non-severe, gentlemen, let's wait and watch. Let's just offer a minimal supportive therapy. His hemoglobin is above 10. His TLC is more than 1500. His platelets are more than 20,000. Just keep a watch on him. If he deteriorates, if he becomes a severe aplastic anemia, we'll take him on. Otherwise, non-severe, let's keep a watch on him. Severe aplastic anemia, I would differentiate if he's less than 40 years of age or more than 40. Less than 40 years of age, you have a sibling, matched sibling donor, take him up for an allogenic hematopoietic stem cell transplantation. Life-saving. You'll celebrate a second birthday. Age more than 40 years becomes a little gray. Till from 40 to 50, if he has an allogenic match sibling, go ahead, do a transplant. But if he doesn't have, then probably I would say intensive immunosuppressive therapy is the way forward. So if you don't have a transplant option, then I would want to emphasize the two things which have a paradigm shift. One is immunosuppressive therapy, and second is supportive care. So can we go to the, so he says supportive care and definitive therapy remains a hematopoietic stem cell transplant and an immunosuppressive therapy. But I'll go on to the next slide and tell you a little more about it. So what is immunosuppressive therapy? So immunosuppressive therapy basically means anti-lymphocyte globulins. So as the word is it's anti-lymphocytes. It's going to go and kill those T lymphocytes which are destroying the pluripotent hematopoietic stem cell. So anti-lymphocyte globulin. We add a calcineurin inhibitor and it acts like a force multiplier. The survival increases. But the great news is, which is not reflected in this slide, is that we have a thrombopoietin agonist, eltrombopag, which an off-label use, and now it's more and more being integrated in a intensive immunosuppressive therapy, is anti-lymphocyte equine ATG, cyclosporin, plus eltrombopag. And I say this with personal validation. I've used it in a few patients with very satisfying results. So literature says that 70 to 90% of people will show a response if you give triple intensive immunosuppressive therapy. That includes the ATG, a cyclosporin, as well as eltrombopag. The second component of the treatment, which is non-transplant, is supportive care. So it's extremely important that we pay due attention to supportive care. And the most important part of supportive care is component support. So you would want to keep the platelets above a bare minimum that the patient does not bleed. You would want to keep the patient free from infections or treat infections very proactively. And you would want to keep his quality of life by keeping a functional hemoglobin of more than maybe 6 to 7 grams per deciliter. Next slide. This is a slide we've already talked about. So the next slide, we just talked about this slide.
Yeah.
So supportive care is something we've just spoken about, blood and platelet transfusions. So as you give blood, you realize that blood has the pros, but the con is an iron overload. So you must think of iron chelation also, which is very important. And components, prevention of infection, platelets, psychological support cannot be underplayed, play a very important role in supportive care. Next slide. So I think this is something we've already spoken about. So can we go to the next slide?
If you allow, sir, can we take a couple of questions?
Yeah, sure. Most
Yeah,
welcome. I think more or less
so-
I've summed up what I
Yeah,
wanted to say, and I would be very
Yes.
happy to take
Yeah.
any question.
That's wonderful, sir. We are really thankful for very informative insights on aplastic anemia. I definitely have a question in the on screen. That's from Dr. Damodar Lele once again. And opinion one: what is the cause of low TC in asymptomatic person accidentally detected during routine checkup? What is alert level for low TC?
Sorry, I need to hear the question again. What is the cause
Yeah.
of?
Yeah, so what is the cause of low total count in asymptomatic person accidentally detected during routine checkup? What is alert level for low total count?
So as I understand your
Yeah, I'm asking about the low total count, and if
as I understand your question is that the patient is asymptomatic
yeah,
and on routine medical examination has been detected to have a pancytopenia, or is it only a leukopenia?
I think it is leukopenia. Dr. Damodar Lele, you can definitely unmute and ask. You are already unmuted. So in case you are there, you can pick up this question directly.
Yeah, Dr. Lele, I'd be very happy to take on your question.
Yeah.
This is leukopenia plus anemia, hemoglobin, low hemoglobin.
Yes. When I say, Dr. Lele, when I say pancytopenia, I mean at least 2 cell lines should be decreased, should be lower than normal. So generally, the most important component of a pancytopenia and an aplastic anemia is low platelets. So you must have a thrombocytopenia. And second, it could be anything. You could have an anemia, or you could have a leukopenia. So pancytopenia does not essentially mean that all the 3 cell counts should be low. It could mean that 2 cell counts are also low, would qualify it to call pancytopenia. If it's detected on accident, you, Dr. Lele, would definitely want to evaluate it further and see whether it's primarily due to a hematological cause, or is it due to a secondary cause like an infection, an autoimmune disease, or unrelated disorders like hypersplenism.
Well,
Dr.
thank you, sir.
Aman, I got a question.
Yeah, sure, sir. Sir, please proceed. Yeah.
Secretariat, please allow me to start my video. Okay.
Yeah.
Dr. Singh, first of all, I compliment you for a wonderful presentation.
Thank you.
Now my question is, long back we used to hear about the stem cell banks, where the
Stem cell bank.
banks, people used to get the storage of their stem cells into the banks at the time of birth. So because this allogenic transplant are giving wonderful results, so what is your comments on that?
Good evening, Dr. Gajendra. Thank you so much for your kind words. So, this had come up in a very big way. The collection and storage of stem cells from the umbilical cord at the time of birth.
Sure.
Now, this is a little bit of a gray area. Why I say gray area is for 2 or 3 reasons. The most important reason is that the collection of cells, stem cells from the umbilical cord are of a definite quantity. And this quantity will generally not suffice when a hematological malignancy is detected in a person who's become an adult.
Okay.
So that quantity per se becomes very minimal. So what is the answer to this? The answer to this is that unless and until you have some kind of cooperation between various banks which are storing this umbilical stem cells to share a particular HLA in case it comes, generally it will not prove to be very useful. So I, as a hematologist, have not really encouraged people to go in for umbilical stem cell storage at the time of birth. It has not, unfortunately, been of any significant evolution into translation into hematopoietic stem cell transplantation. Maybe in the Western world, they have a greater association of different blood banks, stem cell banks, in which one HLA match could, be found in another umbilical cord stored blood, and that could be, added on. But otherwise, I don't think it has brought the results what it promised to do so, unfortunately.
Are there any stem cell banks working in the country at present?
Yes, there are. So there is in Chennai, we have a bank, a bone marrow stem cell bank known as Tetri. It's a non-profit organization, and which has become very functional, and a lot of stem cell transplants are being done with their help. So you have a matched unrelated donor, you put up your HLA and they search, and in case they get. So you have the facility in India, which is gradually now expanding and translating into more and more donors being available who are not sibling donors.
Thank you. Thank you.
Thank you so much, Dr. Singh, for taking up those questions. Thank you so much, Dr. Gajen sir, for an interactive session on this last part. Last question, Dr. Singh, to you from Dr. Ghanshyam Dillera. Dr. Dillera, please, you can ask the question.
Yeah, very nice presentation. Basically, I just wanted to ask whether the use of methotrexate is quite common in the rheumatoid arthritis. So how is the incidence of aplastic anemia in the methotrexate treatment? Thank you.
Sorry, you need to repeat the question. Doctor.
Methotrexate is commonly used basically in the rheumatoid arthritis treatment. So methotrexate, how the incidence of aplastic anemia in methotrexate treatment?
Oh, I think this is such a beautiful question you've asked, because methotrexate, I've treated one patient, a lady who was supposed to get 15 milligrams of methotrexate. By an accident in another station when I was in the army, she had received 500 milligrams of intravenous methotrexate, and she came to us with very severe pancytopenia, and we almost lost her. So methotrexate is the strongest, most potent folate antagonist, and it inhibits DNA synthesis and can be a very important cause of pancytopenia. Having said that, it does not cause aplastic anemia per se. So many times, people who are being treated by the rheumatologist for conditions, arthritis with methotrexate once a week, twice a week, do develop some bone marrow suppression, which may not translate exactly to a aplastic anemia, but definitely reduces the cellularity and causes decreased hematopoiesis. And methotrexate is a drug which should be definitely excluded in your drug history whenever you're taking a patient of pancytopenia. That's a very important thing which I will keep in mind. And if I think methotrexate is the cause, I will discontinue methotrexate, and I will give methotrexate antagonists like active folic acid, that is folinic acid, glucovorin, to salvage the hematopoietic cells.
Great. Thank you so much, Dr. Singh, for
wonderfully
taking up that question as well. And with that, we come to this second session of the day. We really appreciate you sparing time and sharing your informative insights on aplastic anemia. We would love to hear more from you. It was a long presentation. Probably we could have allocated more time and would have done a more interactive session. Look forward to that, Dr.
Thank
Singh.
you, Dr. Pavan.
Yeah.
And it's been a pleasure to interact with you, giving us this chance. Thanks to Indian Oil, thanks to Novartis, and I hope we connect again. Thank you so much.
For sure, Dr. Singh. Yeah. And in the meantime, if you would be staying on this EE platform, there will be some Q&A in the chat box. Just in case you feel like answering them, we will be really glad.
Yeah, I take this opportunity to even thank Usha of Novartis, who's helped me with this presentation. Sure. And thank you very much. I'll be very glad to answer those queries. Yeah. And thank you.
Thank you so much, Dr. Singh. Once again, with that, we proceed to our third and the last session of the day, and that is EPID updates, routine and very usual feature by none other than our very own Dr. Rajiv Kumar Jain, who has been a continued source of information and a lot of insights when it comes to COVID-19 situation. But not wasting any more minute, I would like to introduce Dr. Jan, running briefly his profile here. First of all, very good evening, Dr. Jan. We can see you. Thank you so much for coming up on the screen. Senior consultant, we all know, with the Indian Railways, 40 years of experience in health and hospital administration. Fellow Award of Indian Public Health Association, Fellow Award of Association of Environment and Occupational Health, Delhi. Published, presented more than 145 scientific papers in national and international conferences, journals, and books. Fellowship scholarships by World Health Organization, National Institutes of Health, USA, Canadian Society for International Health, International Clinical Epidemiology Network, and International Society for Priorities in Healthcare. First Secretary and Registrar of the Medical Council, Delhi Medical Council. Member, Managing Committee, Scientific Committee on Epidemiology in Occupational Health, or of International Commission on Occupational Health. Well, this list is unending, and I am sure Dr. Jan has given only few of his key achievements, which can probably put on one page. This list is 24 pointers long, a session in itself, as I always say. So we are really glad to have such a wonderful person among us. And without taking any more time and reading about his accolades and achievements, I hand over the CDIS to Dr. Jan and to share his thoughts on COVID-19 EPID updates. Over to you, Dr. Jan, please. Thank you.
Thank you, Dr. Pavan. So friends, we again come back to know what is happening world over, what is happening in India, what is happening in the States regarding COVID-19. So we start as usual with the COVID-19 dashboard of World Health Organization. Next slide, please. Now, this is an important overall picture of the world, different regions of the world of the World Health Organization, showing through the number of cases and number of deaths. Number of deaths is in the white line, and number of cases are in the columns that are in different colors of the different regions of the World Health Organization. So if you see, there were actually three waves. Three waves you see in cases and three waves you see in deaths. Now, first wave you can say was a combination of America and a bit of Europe, but mainly Americas. Second wave was a combination of Americas and Europe, but the third wave was of Southeast Asia region. Next slide, please. Now, this slide shows the situation in the world, or different regions of the World Health Organization, but I would like to draw your attention to the column on change in new cases in the last 7 days. If you look at the the symbol before the numbers, only one region of the World Health Organization is showing positive and very high positive. It is 44%, and that is region of Africa. The last region where COVID-19 is now growing faster than any other region of the World Health Organization. Next slide, please. Now, if you look at the figure in terms of newly reported cases in the last 7 days, out of 2.577 million cases, 1.167 million cases have been reported by Americas region, and only 631,000 cases by Southeast Asia region, and Europe 329,000 cases, Eastern Mediterranean 199,000, and Western Pacific 123,000. But Africa has exceeded 1 lakh cases in 7 days, 1,25,000 cases. And if you look at the last 24 hours, out of 4 lakh cases reported, almost 2 lakh cases were from Americas, 84,000 cases were by Southeast Asia region, and 50,000 by Europe region. Next slide, please. Now we look at the countries as it happens. out of 4,90,000, 4,08,099 cases reported all over the world in the last 24 hours. Brazil has reported highest 95,000, almost 25% of the world. India 62,480 cases. Colombia 27,000, Argentina 25,000, Russian Federation 17,000, Indonesia 12,990, South Africa 11,767, United States 11,767, UK 10,809, Iran 10,291, Peru 7,713, Chile 6,600. So what we see, majority of the countries are from Americas and especially South America. Look at Brazil, Colombia, Argentina, then we have Peru and Chile. But also in the top 10 now, for the first time ever, South Africa has come. South Africa is reporting 11,000 cases in the last 24 hours. Next slide, please. Now we look at the deaths in the last 24 hours. If you go to the right column, deaths newly reported in the last 24 hours, highest has been Brazil, 2,997 out of 9,749 in the world. So almost 30%, 1/3 of the deaths have been reported by Brazil. India reported 1,587, Argentina 646, Colombia 595, Russian Federation 453, United States 335, Indonesia 290, Peru 261, and Chile 218, South Africa 205, Mexico 196, and Philippines 155. So majority of the countries in terms of deaths are in South America. And also for the first time ever, South Africa is in the top 10 in terms of deaths in the world in any country. Next slide, please. This is the snapshot of India in the last 24 hours, 60,739 new cases, 1,645 deaths, and 20.4 lakh tests yesterday. 7-day average of test positivity is 3.6%, 7.5 lakh active cases and shrinking at -4.9%. Total 2.98 crore cases, 3,85,167 deaths reported till date, and 27.24 crore vaccination doses have been given. Yesterday, 33 lakh vaccinations were given. This is a positive sign. Now it is increasing. Next slide, please. This is important. If you look at the parameters, the 6 parameters, now confirmed cases, deaths, tests per million per day, 7-day average test positivity rate, 7-day average daily growth in percentage, and vaccinated persons with at least 1 dose in percentage. If you look at the left column, confirmed cases in the last 24 hours, out of 60,000 cases, Kerala is at the top, Maharashtra is second, Tamil Nadu third, Andhra Pradesh fourth, Karnataka fifth, 6th is Odisha, 7th is Assam, 8th is West Bengal, 9th is Telangana, and 10th is Jammu Kashmir. So what do we see? South of India, southern India is dominating in terms of confirmed new cases in the last 24 hours. It continues as we had seen in the last week. There is no respite in Kerala. If you look at the deaths, out of 1,647, 45, Maharashtra still reports 1/3, that is 645, 648. But if you look at southern Indian state, Tamil Nadu 287, Karnataka 166, Kerala 90, West Bengal 58, Andhra Pradesh 57, and then only one Uttar Pradesh comes at 51. So deaths also dominant is South India. If you look at the tests per million per day, we still find West Bengal at the bottom with 556, Rajasthan at the bottom with 565, Madhya Pradesh at the bottom 837, and Bihar only 886 at the bottom. These states need to understand that unless they test more, they will never trace and then isolate. There is no way they could, unless you take test, you will not be able to do isolation or have definitive treatment. If you look at the test, 7-day average test positivity rate, the column in blue or purple, if top you find Meghalaya, Kerala, Sikkim, Manipur, Nagaland, Mizoram, all having 11.7, 11.5, 11.1, 9.1, 8.5, and 8.2 as the percentage, while the Indian average is 3.6%. So we can conclude it is still raging in northeast of the country. If you look at the 7-day average daily growth in the the column in yellow, we find Mizoram, Meghalaya, Manipur, Arunachal, Tripura, Sikkim, and Assam at the top. And the growth rate is very, very high. Indian average is 0.22%. There, Mizoram 1.57, Meghalaya 1.1, Manipur 0.99, Arunachal 0.83, Tripura 0.78. If you look at the vaccinated persons with at least one dose in percentage terms, Ladakh, Dadra and Nagar Haveli, Sikkim, Goa, Tripura, Himachal are at the top, but at the bottom are Uttar Pradesh, Bihar, Assam, Jharkhand, Tamil Nadu, and West Bengal. So these states need to ramp up their vaccination drive much faster. Otherwise, they will be caught up in the third wave. Next slide, please. This is again an update on the SARS-CoV-2 variants of concern and variants of interest. As on date, we find now there is a new variant of interest, Kappa and Lambda. If you look at the bottom, on 4th April, India had Kappa, which is B16171, and it's a variant of interest. And then in Peru, on 14 June 2021, Lambda variant was also discovered. At the top, you see 18 December, Alpha variant, UK, 18 December, Beta variant in South Africa, 11 January, Brazil, variant of concern, Gamma, and 4th April, variant of interest and variant of concern on 11th May, the most crucial variant, Delta variant in India. Next slide, please. This is very important for all of us to understand. There are 164 countries with Alpha variant on the top left with yellow. There are 115 countries with Beta variant all across the world, including India. If you look at the Gamma variant, there are 68 countries, including India. And there are Delta variant is 80 countries, including India. And there is always a lineage not specified in 12, which is shown in yellow at the bottom right. Bottom right also has Delta variant in purple color. And you can easily see on all the graphs, India has all the variants, meaning thereby there is more likelihood of further evolution of the virus in India. Next slide. So this is an update on the Delta variant. It has picked up a new mutation. So what is the concerning factor? The Delta variant is a collection of around 13 to 15 mutations, of which several are of concern. At least 4 of these, D614G, E484Q, L4452R, and P681R are known or are being investigated for making the SARS-CoV-2 better able to spread, cause more serious disease, or resist immunity from a past infection or vaccine. Now, it has picked up a mutation known as K417N. Delta with the K417N mutation has been designated as AY1 for now and is informally referred to as Delta Plus. So what do we know about K417N? K417N is a mutation of the spike protein, the portions of the SARS-CoV-2 that help it to latch on to and enter human cells. At a location coded as 417, the amino acid lysine, which is K, is changed to asparagine as depicted by N. In a study by researchers from Rockefeller University, K417N was among 3 mutations that diminished the potency of 14 of the 17 key neutralizing antibodies produced after vaccination with mRNA vaccine. Which other variant is K417N found in? This mutation has also been found in the Beta variant, that is B131351, seen first in South Africa, and some samples of the Gamma variant, that is P1, seen first in Brazil. Both these variants are known to be more resistant to immunity, but it is still being investigated which mutation in particular or what combination of mutation do this. Number 3, how prevalent is it? The AY1 variant has been found in 159 samples worldwide, according to an analysis of GS8 data by outbreak.info. Of these, 8 have been found in India. All of these 8 cases were found between April 5 and May 15. data from Next Train shows 2 clusters of the variant, one in the US and another spread over 8 countries in Asia and Europe. In the UK, the Public Health England, which carries out the most genome sequencing of agencies worldwide, said the first 5 cases there were sequenced on April 26 and were contacts of people who traveled from or through Nepal and Turkey. Where did it originate? It is unclear. One of the earliest recorded samples was collected on April 5 from a man in Maharashtra. Reports this month also said that Japanese authorities found this variant in 13 people who came from Nepal after an Everest expedition. How worrying is it? The closest major analysis is by PHE, that Public Health England, which has found 36 cases of AY1. Of these, it could determine vaccination status of 27. Only 9 had received vaccines and 2 had both doses. The preliminary findings don't yet suggest any major vaccine resistance. Next slide, please. This is a snapshot of 5 months of vaccination. India has inoculated, if you see phase 1, 3,12,000 per day, phase 2, 1.7 million per day, phase 3, 3 million per day, and phase 4, 2.3 million per day. And total doses administered across India till Wednesday night were 216 million doses. And second highest vaccinated population overall is in India, but it is behind with population factored in. If you look at the right bottom, it is below Israel, UK, USA, Germany, France, China, Canada, and Brazil. The pink one is percentage of population fully vaccinated, and blue one is the percentage of population to have received 1 dose. Next slide, please. There is also important aspect of growing urban-rural divide. If red graph is in urban districts and blue is rural districts, and mixed districts are in purple. Urban-rural ratio is in black circle, 1.3, 1.6, and 1.8. So the urban-rural divide is increasing. The gap in the coverage of population in urban-rural areas is the highest in our country and continues to rise. Next slide, please. The state capital bias in vaccination coverage is also an area of concern. Several state capitals have achieved significantly higher COVID-19 vaccine coverage than other districts in the states. Among the 15 most popular states, this gap is the most pronounced in West Bengal and Tamil Nadu. Kolkata, the capital of West Bengal, has given 68.5 vaccine doses per 100 people, the highest among all districts in India, and more than 5 times the coverage in the state's remaining districts. Similarly, Chennai district has administered 44.2 vaccine doses per 100 people, while the figure for the rest of Tamil Nadu languishes at only 9.5. As many as 21 of the 32 districts in Tamil Nadu are yet to touch 10 doses per 100 people. The analysis assumes the coverage in each capital city to be the same as that in the district in which the city is located. In 8 of the 15 states analyzed, the gap between the districts hosting the capital cities and other districts exceeds 10 percentage points. Next slide, please. This is what the total data is. In 14 of the top 15 states, the capital has better vaccine coverage than other districts. And in the red dot, you find districts hosting the capital city. Gray is the other districts in the state. If you see the column in the right is a share of vaccine doses in the state passed in the past month. And then in the middle column, purple is share of cases in past month in the state in percentage. And on the left column, gray is share of population in the state. You find West Bengal and Tamil Nadu, great deficiency in vaccination other than the state capital. This needs attention. Next slide, please. This is showing the pickup of the pace in vaccination. Even on a high base, China was second in increasing the vaccination coverage. If you look at the figure, weekly change in COVID-19 vaccine doses per 100 people in percentage, Japan 29%, China 12%, Philippines 12%, Indonesia 8%. India is also 8%, and Mexico is 8%. But if you look at the cumulative COVID-19 vaccination per 100 people, you find 93 is US, 64 is China, 37 is Brazil, 29 is Mexico, and India is 18.5, and Japan is 20.9. Over the past 4 weeks, the pace of COVID-19 vaccination in India has increased progressively. In the past week, India averaged 3.3 million doses per day, nearly double of what it was more than a month ago. In the past week, India registered a week-on-week growth of 7.8% in vaccine doses given. In the 3 weeks before that, it had managed 8.7, 8.3%, 7.4%, and 5% growth. Among the 10 most populous countries, the US leads in COVID-19 vaccine coverage. The world's largest economy has already given 93.3 vaccine doses per 100 population. This is followed by China, 64.2, and Brazil, 37.8. Despite its high base, China registered the second highest weekly growth in the past week. On this count, Japan remains the leader, registering a weekly growth of 29.3%, albeit on a smaller base. India retained its fifth position on weekly growth. Next slide, please. This is the issue of Northeast concerns. Higher vaccination coverage is imperative as the easing of curbs raises the possibility of a third wave. For now, the curve of new reported cases continues to trend lower after peaking in May second week. This week, the number of new cases declined by 30% over last week. A week ago, 624 districts had reported a week-on-week drop in new cases. This week, however, 53 of these districts reported an increase. Assam had the most districts on the list. Golaghat reported 1,314 cases this week, 20% more than last week. Last week, it reported a 19% decline. Similarly, Shivsagar, 711 cases, reported a 35% increase after a 32% decline. Several districts in the Northeast are seeing spikes. West Kameng in Arunachal Pradesh reported 787 new cases this week, its highest ever weekly tally. Long Talai in Mizoram reported 210 cases this week against 48 last week. Meanwhile, Coimbatore, 12,886 cases replaced Bangalore urban, 11,213 cases as the district with maximum new cases. If you look at the left graph of India, Coimbatore has replaced Bangalore urban for the maximum new cases. Coimbatore, 1288 cases, Bangalore urban, 11,213, East Godavari, 7,900, Thiruvananthapuram, 12,514, and Pune, 8,641. Next slide, please. This shows the toll in Odisha. Deaths in Maharashtra spiked this week as the state updated its numbers. Maharashtra 1260, Odisha 44. Typically, a decline in deaths follows a drop in new cases. After 2 weeks of decline, India registered a 3% increase in deaths this week, 22,428. Most states have reported a fall in numbers of for the last 2 weeks, but Maharashtra and Odisha were exceptions. As many as 29 of 35 districts in Maharashtra and 13 of the 30 districts in Odisha reported an increase in weekly deaths. In Maharashtra, the main reason for the highest tally was the state classifying more past fatalities as COVID-19 deaths. In Odisha, Cuttack and Bargarh districts remain points of concern. Cuttack has seen rising deaths in each of the last 4 weeks, 3 deaths in the last week of May, followed by 15, 23, and 27 in the 3 weeks of June. Bargarh has reported 33 deaths this month, of which 22 were this week. What is happening in Odisha is also underscores the need for robust vaccination coverage beyond the state capitals. Next slide, please. This is an important slide to underscore old deaths and new data. There have been 19% increase of deaths added to the country's tally in the past month for reconciliation by states. The death reconciliation has pushed up the country's death count in the past month, and in extension, it implies that death numbers reported during the peak of the outbreak during April and May were underreported. If you look at the bar graph, reconciliation is shown in purple and daily deaths earlier reported are in red. Next slide, please. This is a summary, or in one snapshot, you get the calculating India's excess deaths due to the pandemic in Andhra Pradesh, Assam, Karnataka, Madhya Pradesh, and Odisha, and Tamil Nadu. What you see, Andhra Pradesh, excess death was 34 times the official COVID-19 deaths reported in the state in 2021. Assam, it was excess deaths with 30 times the official COVID-19 deaths reported in the state in 2020. Karnataka, deaths, if you see, excess deaths were 5 times the official COVID-19 deaths reported in the year 2020. In Madhya Pradesh, excess deaths were 42 times the official COVID-19 deaths reported in the state in 2021 till 11th of May. Tamil Nadu, excess deaths was 6.2 times the official COVID-19 deaths reported since the state start of the pandemic, that is April 20 to May 21. If you look at the entire figure, then you understand the importance of excess deaths calculation. Excess deaths or mortality is generalized term that refers to the total number of deaths from all causes during a crisis that is above and beyond what would have been expected under regular condition. During the COVID-19 outbreak, this data is being used to count the number of deaths that would not have occurred had the pandemic not taken place. The calculation for the state-wise excess deaths are based on data accessed from the civil registration system, that is CRS, a national system of recording all births and deaths under the Office of the Registrar General of India and implemented on the ground by state governments. And what have they found? Based on the CRS data for the past few years, 3 news organizations, that is Scroll, The Hindu, and the News Minute, were able to assess excess death calculation from Andhra Pradesh, Assam, Karnataka, Madhya Pradesh, and Tamil Nadu. And that is what is shown in the charts, the 5 charts of 5 states on the right side. Next slide, please. Another event which has occurred this week is the global COVID-19 deaths have soared past 4 million. Coronavirus-related deaths worldwide passed a grim milestone of 4 million on Thursday, according to a tally maintained by Reuters, even as many countries across the globe struggle to procure enough vaccines to inoculate their population. While it took over a year for the COVID-19 death toll to hit 2 million from the day the first ever person died from the disease on January 11, 2020 in Wuhan, China, the subsequent 2 million deaths were recorded in just 166 days. Next slide, please. Daily global deaths are still high, but are starting to drop. This is what is shown in the graph. 7-day average in red and daily deaths in blue are shown. 4,903,000, the total number of people who have lost their life to COVID-19 across the world. Next slide, please. There has been uneven distribution of deaths, creating COVID hot zones. CFR in world's worst hit nations: Peru 9.4%, Mexico 9.4%, Italy 3%, Brazil 2.8%, UK 2.8%, Colombia 2.5%, Russia 2.4%, France 1.9%, USA 1.8%, and India 1.3%, while the global average is 2.2%. Total deaths, if you see at the bottom, the world graph, the total deaths due to COVID-19, India 385,000, USA 616,000, Russia 128,000, UK 127,000, France 110,000, and Brazil 496,000, Peru 189,000, Colombia 98,000. Top five countries by total number of deaths: USA, Brazil, India, Russia, and Mexico together have been responsible for nearly 50% of all deaths in the world. Peru, Hungary, Bosnia, Czech Republic, and Gibraltar have seen the highest death rates when adjusted for population. A total of 275 people have lost their life per million residents in India. At the other end of the spectrum are China with 3 deaths per million, New Zealand with 5 deaths per million, and Singapore 6 deaths per million, which are among the regions that have seen the fewest fatalities with respect to their population. Next slide. This is fatalities dropping in regions with high vaccination rates. 7-day average daily deaths are shown in the graph. Oceania is in the blue, dark blue. Africa is light blue. North America is also blue, and Europe is brown, and South America is yellow, and Asia is red. So you can see daily deaths. The lower the vaccination, higher is the number of deaths. A closer look at the regional breakup of daily deaths, however, provides some much needed good news, especially when seen alongside vaccination figures. This trend is most clearly visible in numbers from North America, where the 7-day average of daily deaths and is currently the lowest since early April 2020. On average, 616 people have died every day on the continent in the past week, a drop of nearly 88% from the peak there. North America, unsurprisingly, is also the region with the highest vaccination rate in the world. More than 40% of all North Americans have received at least one dose of the vaccine. Similarly, daily deaths in Europe, where over 37% of residents have received at least one shot, have dropped 84% from the peak levels. But Asia and South America reported 4,094 and 3,836 daily deaths in the past week, respectively, together responsible for nearly 9 out of every 10 fatalities in the world in the past 7 days. Around 21% of Asia's population has been inoculated with a single dose of the vaccine, while this number is 24% for South America. The correlation is too stark to miss. It means take the jab as early as possible. Next slide, please. This is another way of the data mapping, which is important. 2 waves, but similar age-wise spread. The proportion of children among those infected did not drastically change between the first and the second wave. This is from the government data, 1 to 10 year. First wave is blue, second wave is red, 3.28, 3.05. 11 to 20 years, 8.03, first wave, 8.57, second wave. 21 to 30, 21% and 22%. 31 to 40, 21%, 22%. 41 to 50, 17, 17%. 51 to 60, 15 and 13%. 61 to 70, 9% and 8%. 71 to 80, 3.7, 3.35. So the data shows that there is similar age-wise spread. Next slide, please. So another important data which has come out from AIMS WHO combined study is that kids and adults have same antibodies across 5 study sites. The survey found 55.7% antibodies in kids as compared to 63.5% in adults. And further data will be available during this week. This is from 4 sites, 5 sites. There will be other sites which have also been included. That data will be coming out this week. But this is important, that children have been affected as equal as adults. So there is no difference in terms of antibody development. It's almost similar. Next slide, please. This is another way to look at it. All the data is directed to guide how to prepare for the third wave. The second wave of COVID-19 infections in India peaked on May 9, 2021. The 7-day moving average daily cases has now come down to 85,807 from peak of 391,890. The fact that India faced a severe second wave of infections, which overwhelmed the health infrastructure, has underlined the importance of preparing well for the third wave. Of course, the pace of vaccinations will matter the most in determining whether or not there is a nationwide third wave. Vaccinations apart, there are 4 things that what must be done to reduce the impact of a possible third wave of COVID-19 infection. What are these 4 things? Number 1, next slide, please. Testing facilities need to be expanded. If you look at the India map, testing in time and isolating infected patients is the key to containment of COVID-19 infection. Whether or not people get tested in time depends on access to testing facilities. A symptomatic person is more likely to get a test done if the testing center is 1 kilometer away from the house than if it is located at a distance of 20 kilometers. Paid and free tests at government facilities are also likely to make a difference, especially for the poor. Data from COVID-19 sample collection management system of the ICMR shows that testing facilities are extremely skewed in states such as Bihar and Uttar Pradesh. The data shows that as on June 12, the median number of sample collection centers, including mobile units in districts and states such as Karnataka and Gujarat, was 90 and 68. This number was just 2 in states such as Bihar and UP. It needs to be kept in mind that these are median values, and therefore half the district will have a lower number of sample collection centers. 31 out of 735 districts in the country listed on the portal have no sample collection center. 99 have just once. Clearly, this needs to change if the pandemic has to be monitored better. Next slide, please. Second, people, especially the poor, need to be encouraged to seek medical advice. To be sure, expanding testing centers will take care of only part of the problem. The 2017-18 survey on health consumption by the National Statistical Office, NSO, shows why in India, whether or not people seek medical advice when they feel sick is linked to their economic status. The poorest 20% of people, as per monthly per capita consumption expenditure, are almost 3 times more likely to not seek medical advice than the richest 20%. Lack of health facilities in proximity and affordability are bigger reasons for not seeking medical advice among the poor than the rich. The biggest reason for not taking medical advice across classes is the ailment not being considered serious. Given the fact that COVID-19 begins with common symptoms such as fever and cold, a behavioral change is required when it comes to suspected patients seeking early testing and treatment. If you look at the right column, whether treated with medical advice, yes, with medical advice, much higher in top 20% and much lower in bottom 20%. And the reason, if you look at blue, shows no neighborhood facility or too expensive in blue. Yellow shows cannot afford to wait long due to domestic and economic engagement. And red, most important ailment not considered serious enough. And black is others. It is very reflective, and what we have said is true. Next slide, please. Number 3. Acknowledge the financial burden of COVID-19 hospital admissions. There is no real measure of financial burden of health expenditure due to COVID-19 infections. The NSO survey can be used to estimate what this health spending shock could have done to household finances. According to it, in 81% of cases where hospitalization was required, excluding childbirth, the expenditure was met by family income or savings. 11% of such cases were financed with borrowing. 3.5% of these were met with contributions from friends and relatives, and 0.4% required sale of physical assets. To be sure, the average hospitalization spending in the NSO survey was 22,380 rupees per case. For cases within the top 10% bracket of spending, including spending of 50,550 or more, reliance on borrowing, contribution by friends and relatives, and sale of physical assets increased significantly. An average of COVID-19 hospitalization case is likely to cost much more than rupees 50,000. Our 2016 Mint analysis of the household survey on India's citizen environment and consumer economy, that is IEE 360-degree survey by Pramit Bhattacharya, gave an idea about the potential impact of health stocks on household finances. The survey showed that 3% of households in top quintile, that is the richest 20%, faced a health shock that wiped out more than a fifth of their annual income. The comparative figure for the bottom quintile, that is poorest 20%, was more than double at 6.8% of households. These numbers are likely to have increased many-fold during the pandemic. And if you look at the figure, major sources of finance, all hospitalization on the left side, and top 10% most expensive hospitalization on the right side. And you can see yourself how household income savings decreases on the right side, borrowings increases on the right side, sale of physical assets increases on the right side, contribution of friends, relatives increases on the right side. And that is very reflective. And last but not the least, number 4, expanding health insurance cover will help. Over 3/4 of hospitalization cases in India involved individuals who were not covered by health insurance. According to the 2017-18 NSO survey, access to health insurance is correlated to incomes, and the share of hospitalization cases not covered by any kind of insurance increases from 68% among the richest 20% to 85.5% among the poorest 20%. Even in cases where health insurance existed, it did not cover the cost of entire treatment. NSO survey shows that on average, health insurance was paid for only 10.2% of the medical expenditure and 9.1% of total expenditure, which includes cost of transportation, transporting the patient, as well as the cost of food, lodging, transports, etc. for the household. in cases that require hospitalization. To be sure, the survey was conducted before the rollout of the Pradhan Mantri Jan Arogya Yojana, PMJAY, which aims to cover 107.4 million households or 500 million beneficiaries under health insurance. So the insurance coverage numbers could be underestimated. The PMJAY website says that there have been 18.6 million hospital admissions under the scheme since its launch. If you look at the figure on the right side, hospitalization cases that affected people without any health expenditure or insurance scheme on the right side is much lower, that is the top 20%, and the left side, bottom 20% is highest. So this is an important observation, and this is comprehensive strategic data input for the preparation for the third wave. So in summary, I would say we are out of the curve of the third wave in the world, second wave in India, but we must use this time for preparing for the third wave, which is likely to happen. And today you must have seen Dr. Guleria said within 6 to 8 weeks, a third wave may strike India. Thank you so much for the patient listening.
Thank you so much, Dr. Jan, for that elaborate overview and emphasizing on the third wave that we have been definitely getting to know. Yes, as per AIMS and as per Dr. Guleria, there has been a study, as you already shared. So we have some findings, which is probably a sigh of relief for kids. Open the floor immediately, opening the floor for the questions, some 2-3 quick questions. We are already 36 minutes past 8 o'clock. And over to the audiences, over to the attendees and the panelists, if anybody has any questions, please. Thank you so much, Dr. Jan, once again. Well, I have received one question from Dr. Dulera. Dr. Dulera, you can actually unmute yourself and ask the question, please. Okay. Yes.
Yeah. Very nice presentation, Dr. Jain. Basically, I just wanted to ask, especially as the Delta variant is having a more infectivity and it is spreading very faster. So apart from the COVID appropriate behavior and double masking and then basically rapid vaccination, what else we can do so that we should not land up with a severe third wave?
Thank you, Dr. Dulera. Very important question. Well, the science is showing enough evidence of the additional methods of preventing transmission. As you know, transmission is much faster. We have discussed earlier as well. Number one is ventilation. Don't spend more time in indoor spaces which have poor ventilation. Number two, do not attend events which have mass congregation of people, and especially in poorly ventilated spaces. Spend least possible time, even if you are using double mask or even if you are using social distancing, continue to adopt the basic scientific evidence that ventilation helps, open spaces help, closed spaces will increase your vulnerability. Do not travel in closed AC buses or AC cars. If car is there, AC should be off, windows should be down. And do not travel in public transport. Prefer to travel in individual buses or individual autos or individual car. You drive yourself and travel alone. The best is if you travel in public transport, use an auto rickshaw and do not use a car or a bus. That because auto rickshaws are very open and only one driver and one passenger or max 2 passengers are there, and both have got 100% ventilation all through the travel. So it protects you a lot during travel. These are the basic precautions which one can take easily and remain protected from the Delta variant. But there will be other variants coming. Please remember, India is having at the moment all 4 variants of concern. And India is also having number of variants of interest as well in India. That is the evidence already gained in India, which can easily convert into variant of concern. VOI to VOC is very fast happening all over the world. If you look at Europe, entire Europe is flooded with Delta variant now. And it has started replacing Alpha variant in USA. Delta variant is the highest growth in USA today. In the past 15 days, if you look at the figure, it is replacing alpha variant in USA.
Thank you so much, Dr. Jain, for taking that question. From our esteemed panelist, request.
Thank you, sir. Thank you.
Yeah, thank you, Dr. Dulera. Request, since Dr. Pingley is here, and if Dr. Pingley can throw some light and share his thoughts. I can see a hand raised by Dr. Sandeep Sharma. So by that time, Dr. Pingley, can you hear us? Okay, we are not able to hear you. Probably you are speaking.
Are you able to now?
Yes, Dr. Pingley. Yes, we can very clearly. Please.
Yeah. See, Dr. Jain has given a very well-researched lecture.
Yeah.
And thank him a lot for that. Because it's a very nice update for us, whatever has happened throughout the week. Dr. Guleria's statement today is really worrisome. That we are not able to control the appropriate behavior of the people, and for its next wave in 6 to 8 weeks. So if we are not able to control the people, then this will go on, and the variants of concern or variants of interest will keep on arising. Mutation will be there. Our vaccination is, whatever we may say, is not going to be very fast because of the vaccine availability, and therefore there is certainly a matter of concern. So let's see how we tackle that. Yeah, that's all. Thank you.
Thank you so much, Dr. Pingley, for sharing those thoughts. Yes, indeed, situation is worrisome. Keeping fingers crossed to see some ray of hope. And with that, moving to Dr. Sandeep Sharma. Please, Dr. Sharma.
Yes, thank you, Dr. Pawan. Pawan, actually, the question is related to what Dr. Pingley has also highlighted. Like Dr. Randeep Guleria here said that we may face or we may encounter this third wave in another few weeks. So what will be the exact cause of this third wave? It will be the Delta variant or new variant of concern, or our complacent behavior, or the easing out of the lockdown. What will be the main reason for that?
Very important question, Dr. Sandeep. Thank you for asking this question. All the waves are a result of a combination of factors. A balance between lives and livelihood. This is a normal feature of any pandemic or epidemic. Now, if you see vaccination, behavior, and also evolution of the virus, these three factors interplay, and these keep on interplaying. Now, if you had seen the way Indian figure is evolving, what we saw, Maharashtra was having a different evolution, Delhi was having a different evolution. Delta variant was evolving very fast, and the way it evolved was reflective because of the secondary factors of insufficient immunization, vaccination, and COVID inappropriate behavior of the population concerned, especially in the metropolitan areas, and also mobility. Mobility between urban and rural areas also matters a lot. And this will keep on happening till there is a balance, till endemicity is attained. Pandemic will remain, pandemic is there, and pandemic has not gone. Till pandemic is declared to be off by the World Health Organization, one needs to understand it is happening in all three areas in terms of vaccination, in terms of COVID inappropriate behavior, and in terms of evolution, molecular evolution or genetic evolution of the virus. These three factors will keep on interplaying with each other, and this from one continent to another continent, one country to another country, one district to another district, it keep on spreading and coming back because of the third factor of reduction in immunity over a period of time. So population which has got antibodies may not be having effective protection against the same virus, and also the factor that virus has evolved. So these factors will continue their interplay. And this is normal in any infection, and more so in viral infection. It has been seen in H1N1, it has been seen in Ebola, it has been seen in influenza, it is being seen in SARS-CoV-2, but on a much larger and much devastating effect scenario.
So,
Thank you for
sir,
asking.
everyone is now opening their workplaces. Still, the attendance is restricted as per the guidelines. So we need to still advise our workforce that you need to be very careful. You should not be complacent, and you should take all due precautions, because still the virus is only suppressed. It has not been eradicated. So until unless this positivity rate is below 5% for a long period, we can't say that it is under control. So precautions, they need to be in place.
Very true, very true. If economies have to continue their growth or even normalcy, COVID appropriate behavior with increased vaccination is the only solution. Both have to play together. One, only vaccination will not be sufficient. Only COVID appropriate behavior will not be sufficient. And last factor I've been saying again and again, all workplaces have to understand that ventilation matters. Keep your doors and windows open, even in air-conditioned spaces. When you're working in closed spaces, keep your doors, windows open and the fan on.
Yeah. Thank you so much, sir, for sharing those thoughts related to the concern. Over to Dr. Shah, Dr. Divyank Shah, for his thoughts.
Yeah, good evening, sir. Can you hear me?
Yeah, very well. We can hear you quite clearly.
So once again, thank you, Dr. Jain, sir. As usual, you are having the tremendous research, data, and analysis interpretation. Just to supplementary questions to Dr. Sharma has asked. What will be the strategy of occupational health physician in the factories and especially in the offices? Because now the management is asking to come back to 100% back work from office, and then there is a third wave is in the near radar. How to convince and what should be the strategy to convince the management that still the threat is not there and let's not lower our guard?
Very, very pertinent question, and that all occupational health physicians need to understand the epidemiology, the district data where the factory is situated, and act very dynamically and very, very efficiently. Number one, keep an eye on the district data that is available in the public domain. Number one. Number two, keep your personnel being tested through rapid antigen tests on random basis also, and on symptomatic basis as well, at least once a week. If you cannot test 100%, do test at least 50% of the people who are working in closed spaces, either in factories or offices. Those people who are actually turning out to be positive, institute monitoring mechanism faster, and it should be very dynamic. They should not be left to their own self. They should be handheld and helped in managing their disease, and also, last but not the least, manage post-COVID situations for at least 3 to 6 months. The individuals who have had COVID, there should be a mechanism to handhold them for follow-up in a systematic manner for at least 3 to 6 months. As now data is showing that if you monitor, then the complications, if detected early, can be managed and outcome could be much better. This gives confidence to other people who have not been infected that if they suffer, they will be, their organization, their employer would be taking care of them. Right? So these are the broad strategies, and also keep your interaction with the district health authorities on a regular, continuous basis. That helps because in times of crisis, it is the district administration which will come to your help in a multifarious ways.
Thank you, sir. Just what I believe that the first wave was of because of the ignorance. Second wave was because of the complacency. And third wave would be because of the stupidity. Your comments?
Yes. Well, very well said, Dr. Divyang. Very well said.
Okay. Thank you so much, Dr. Shah and Dr. Jan.
Dr. Pavan, in addition to what Dr. Divyang and Dr. Rajiv Jain has said,
Yes,
I just
yes.
want to say 2-3 points. Like in this, in anticipation of the third wave, in the first wave, second wave, we have taken all the precautions at our workplaces. But right now, 2-3 factors which Dr. Rajiv has also stressed upon. Like number one, we have to stress upon the vaccination. We need to ensure 100% vaccination of our employees, because it gives some sort of protection to all people. Number two, ventilation, because earlier the this air transmission was not authorized by this WHO. Now WHO says that some sort of airborne transmission is there. So we need to avoid closed spaces, and proper ventilation should be there in offices. Then number three, what Dr. Rajiv sir has also stressed upon, we need to be very careful about the post-COVID syndrome in our employees who are coming to office, and they need to be strategically told that they need to be careful for at least 3 months. As the effects of COVID, especially after the second wave, the people who have been affected by Delta variant, people with comorbidities, they need to be very careful about their blood sugar levels, whether they had been on a steroid or they had earlier been hospitalized for a long time. So clotting effects, thrombotic effects, all these things, they need to be very careful. Yeah. And they need to be properly taken, like reviewed by the occupational physicians, as Dr. Divyang said. What we should do, we should take care of all these things. And in addition to all the hygiene norms, distancing norms, we need to take care of the ventilation, vaccination, and thirdly, this post-COVID care of our employees. I think this will take care.
Yes, I think I cannot agree more. Rather, we all cannot agree more on this. Thank you so much for sharing your thoughts, Dr. Sharma. This definitely will help. Let's see how well we are prepared and how well we can defeat that. And then move with those words, coming to Dr. Thagaraju for his final words probably, and also after that they will be concluding remarks. Dr. Thagaraju, please.
Thank you, Dr. Pavan. Thank you very much for the calling me. And both the lectures were very, very good. And Rajiv Jain explained very beautifully. And it is so nice that he has, I think he has prepared wonderfully. And a lot of homework has been done, because it is very difficult to come out with such a glamorous lecture. Wow, wonderfully Rajiv Jain prepared very, very nicely. And both the lecture on the aplastic anemia and as well as the chronic myeloid leukemia was very, very good. I think we have to congratulate you, your Delhi team, because see, education, see, you are educating all of us. Very, very, very nice. Because today we need so much knowledge to practice or to talk to anybody. Suppose if anybody asks some questions about COVID or anything about this medical, this one, we should have a first-hand knowledge, because that time we cannot go to the books or the Google or anything. Really, we thank the Delhi team, especially Dr. Gajendra Kumar, Dr. Sandeep Sharma, Dr. You, and our Senior Vice President, Dr. Rajiv Kumar Jain. Wonderful. You are all prepared very well, and really we are highlighting us, and we were very much thankful to you for the knowledge. And this one, please continue as long as this third wave till there. And one thing I would like to add, this especially the origin of the third wave, people used to say that it has come from the Britain, this is the Delta variant, and it is a 40% more infectious than any other variant. And we are, Guleria also said that, and we are really worried because one experience is what this one is, people, we are not having a very good hospitals or nursing homes which can tackle this. And many of our doctors, they convert within no time, they convert there is small hospitals into oxygen hospital, and they start giving oxygen and all. I have visited one hospital because I have sent one patient because he was not having any, and he was not having money, and also he was not having, not getting an hospital. So we sent nearby. So this man was admitted. So 4 beds were there. And around 10:30 with PPE kit, I went to the room and talked to the person who I sent to this one. And I talked to him. He said he spoke. Then also, courtesy sake, because it is nearby our place, I talked to all the 3 people. They were all right. And next day I came to know at 3 a.m., one gentleman has died. Another 3:10, another gentleman has died. Another 3:20, the other gentleman has died. So the man who have sent, he has died at around 7 o'clock. All the 4 people have died. They were all talking. They were on oxygen, means cylindrical oxygen. The cause is very difficult to analyze. Either over oxygen, or they may be psychological, this one. And he has told in the night to his son, you take me here, I'm very psychologically I am upset whether I will leave or not, like that. So third wave has to be prepared very nicely, because we should have a very good hospital, we should have a very good intensivist, we should have a very good pulmonologist, we should have a very good pediatrician, and well prepared oxygens, and even concentrator and all may not be working because it is a liquid oxygen which will work in case of children. And all these things one should think of. Simply whether he is an MBBS or MD or anything, if they think of money, I think we will totally, we are not doing any justice to the public. And one more thing I would like to tell. One of the intensivists in our Karnataka, some educated people asked to that a 9-month-old pregnant woman wanted to, she is having a corona positive, wanted to get admitted. This gentleman has taken the patient to an hospital where there is no gynecologist is available, where there is no operation theater also available. And what happened? This gentleman has asked a question to the intensivist, because is this possible to treat this patient in this hospital? He said, okay, we will do the preliminary and all. Then they charged nearly 4 lakhs rupees for 2 days. Then they asked the severe questions that is it possible. Then they shifted to another hospital. In that hospital, they have done cesarean. And within 24 hours, both the mother and the child are all right. Without oxygen, they are all right. So this man, they have naturally, they have collected around 4 lakhs rupees. So they have asked this intensivist, please return back this 4 lakhs rupees. Why did you admit that lady into a place where there is no gynecologist is available, no doctor, no operation theater is available? So this man could not answer anything. They have pushed him into the wall. Then somehow police has come this and he has in a WhatsApp group, in I think in all the WhatsApp group of IMA in Bangalore as well as the rural Bangalore, it has appeared. This intensivist has asked the police, he has asked the IMA president to help him. See, he is an intensivist. He should not have practiced, because intensive work is only in a hospital.
Absolutely.
That is number one. Second thing is, we should not have taken the patient to a 9-month-old lady, should not have taken to the place where this. These are all the problems now doctors are also facing. Simply they are, and they see, in certain hospitals, especially in Christian hospitals, they do 2 times counseling. They say your patient condition is like that, his oxygen saturation is like that, he needs, we are giving so much treatment, and they still is not coming up. And if you wanted to take him to the better hospital, you can take him. But if you permit us, we will take this patient, and they will take it in writing, especially in Christian hospital. In a smaller hospitals and all, very, very critical patient, about 70 to 80% of the oxygen and all they are taking. I think.
Sad state of affairs, Dr. Thiagraju. Both the stories are quite disappointing. 4 people dying, and then this pregnant lady suffering financially and commercially. Such a big hit, blow to the family. I completely agree. Sad state of affairs.
In Karnataka, in Bangalore, especially 200 deaths are there, means nearly 140 deaths are from hospitals.
No, I completely agree. A lot of mismanagement has happened. We have seen, we have observed. Thank you for sharing and highlighting this issue. We will see how this body can probably arrange something and throw some light, and then we can be better prepared. I really appreciate you for sharing those wonderful thoughts and words for us, whatever work we are doing, but it has never been possible without support of people like you and without support of team that is behind. So once again, cordial thanks to everyone and all of you at the platform right now. My apologies. We were trying to round it, probably wrap it up by 8:15 or something, but then I think we will see how best we can utilize from next time onwards, and then we stick to time. With those remarks, I would once again thank everyone, and would like to conclude. If Dr. Jan has anything to say as final word, else we will conclude the webinar of today.
I have nothing to say. In fact, discussion is very enriching, and I appreciate attendees. It's been more than 2.5 hours now.
Yes.
This session has gone. I must appreciate the patience and the perseverance of all the attendees. Thanks for all the interest that you've shown. Thank you.
Thank you so much, Dr. Jan. With that, I once again extend thanks on behalf of AOSD. Have a wonderful good night, and definitely wonderful Saturday evening and Sunday. Thank you.
Thank you. Thank you very much.